И мы бы хотели обсудить увиденные случаи, в первую очередь с нашими зарубежными экспертами и с нашими. Секундочка. If you don't mind, today in the morning we'll already start to discuss with you the differences in Japanese approach to the colorectal lesions and the Western world approach. So if you don't mind, could you let us start from the last case by Douglas Rex and start from the initial diagnosis of this lesion and finish with the ablation of the ages. What would be your approach to the same lesion? Could you please comment?
Okay.
It will work simultaneously.
Okay. Actually, in Japan, so the diagnosis itself is, I agree with Dr. Rex. The lesion has a protruded part indicating the adenoma component, and at the same time, flat type component indicated somewhat the isolated component. So the actual diagnosis itself is, I agree with Dr. Rex. And approach itself is, in Japan, as you know, we prefer performing ESD, particularly for colorectal lesion is very easy part and very safe part. And considering the risk of recurrence, our idea is, why don't you resect in envelope resection? Because it takes not so long time for that kind of lesion located in the rectum. And the ESD itself is not so difficult in the rectum part. So in Japan, many doctors prefer performing ESD for that lesion. However, at the same time, we can understand that lesion actually has a low malignant potential, so piecemeal resection can be acceptable for that case. We can understand that lesion.
In case if it would be suspicion for at least intramucosal cancer, the same case, would you definitely go for ESD or recommend ESD?
Okay, if there's no risk of intramucosal cancer, the cancer's component, in that case, piecemeal resection can be acceptable, and considering the balance between risk and usefulness, we sometimes choose piecemeal resection. However, I'm afraid that, so Dr. Rex explained that actually the recurrence rate is not 0% after piecemeal resection, even for that kind of lesion. So in that case, we actually considering that aiming at 0% of recurrence, we prefer performing ESD in Japan.
Thank you. One more question for you, and later on we will ask the same question for Jan and Michel. I understand prospective randomized trial from Michael Borg and St. Mark's showing that avulsion or not avulsion, ablation both of APC or soft coagulation with the tip of the polypectomy snare reduce the number of recurrency. But it's still not clear for me what the reason for this recurrence, because if you see the really clear margins, what is the actual remnant which later on will be the actual not residual but recurrence. Would you also in your clinical practice make this ablation?
No, actually I totally agree with Professor Hilder on that point. So if that lesion has a risk of recurrence, maybe that is not due to the remaining of the rim of the lesion. I think that so. In that case, I think I don't mean to be against Dr. Rex, but at the same time, from my viewpoint, actually the coagulation for the rim itself is not so logical, I believe that. So endoscopically, there's no obvious remaining part, and actually if the recurrence occurs, that's not due to the remaining part of the rim. So I think that we have to reconsider and discuss about that point. I totally agree with
Let us ask the same question to Jan, please. What's your approach?
So our approach, one, I was a little bit initially concerned with that nodule that was there. I think the most important thing that what we're learning now is histology is not as important as the endoscopic characterization of these lesions. And we need as endoscopists to fully understand the morphology characteristics before we ever start removing a polyp like this. Doug Rex will tell you this, Michael Burke will tell you this. So I think it was correct. I think there was a very low risk there. Once he turned on NBI and he very carefully looked at that nodule, the nodule did not look nearly as suspicious as initially I had thought. Now, if that was a suspicious nodule, and I think Doug said this, then I think that this would be a case that the patient should probably have ESD and not piecemeal EMR. So I agree with Doug going forward. I would have done the exact same thing. In terms of snare soft tip coagulation, at least at this point, you can't argue with the evidence. And the evidence shows that there's significantly less recurrence, at least from the Australia group. And I would say that Michael Burke in the Australia group is the leading center in the world for this type of research. Yeah. So I would agree.
May I interrupt you?
Yeah.
We agree with the results of the prospective randomized trial.
Yep.
But what is the evidence, not evidence, but what is the reason?
The rationale, the biological
what is the biological rationale for if we see the completely clear margins?
I think that's just it. I don't think we're actually truly seeing the clean margins. I think there's probably very small lesions that may still be there that we're not good enough yet to really visually see, and it may clean up those areas that we're not completely seeing. That's what I think.
Probably it's another reason to perform ESD from the very beginning, not the piecemeal resection.
But I think that ESD, there are still not enough people, and I don't think there are going to be enough people that it's going to be as a widespread utilization.
Of course.
EMR.
We understand it, but we're talking about the future trends. What should we do to learn soft coagulation of the edges, or better learn ESD technique? That's my question.
I think we need those comparative data.
Sure. Sekaguchi-sensei, please.
Evidence is very important, and I believe in the importance of evidence. However, at the same time, endoscopic treatment has a technical aspect, and if the lesion is beautifully resected even after piecemeal resection, like the last case, in that case, I think that routine coagulation is not necessary. However, at the same time, piecemeal resection has many kinds of piecemeal resection in the daily practice. So many of the piecemeal resection has we are not sure that beautiful clear margin is accepted. In that case, we believe that of course coagulation is useful, and even in Japan we sometimes do the coagulation even after ESD if we are not sure that complete resection, complete endoscopic resection is not achieved. However, routine coagulation itself, I don't agree with that idea.
And to be on the side of the Sekaguchi-san, you talk about the small remnants on the edges. At the same time, after piecemeal resection, we can have the same small islands in between our snare resection.
If your technique is not good, yes, you're at risk of leaving islands. So you have to be very elegant about how you do piecemeal EMR.
Sure. Chris, please.
This is a very interesting topic, and I've been following this for a while. When the first study from St. Mark's came on using APC ablation to the edges, and it was a positive trial. And then we did one study and we looked into our own results, and it didn't make any difference to whether you do APC or not. After that, Michael Burke did this study where he did extended resection of a normal tissue and showed that it didn't make a big difference. But the difference what he showed now is that if you do the soft tip coagulation, then it reduces it. So essentially still we don't know what is the right thing to do. And I think important thing now here to see other centers doing this trial to see whether it's reproducible what he has done, and also to compare extended resection of normal mucosa versus soft tip ablation to see whether it makes any difference. Because these trials have come from high volume centers, 1 or 2 studies, where it has not been reproduced in other centers.
Yeah, thank you.
So, although if you are going to treat the edges, I mean, I would use at this point snare soft tip coagulation and not be using any more APC.
Yeah, it's mixed results, and we're talking about 1 study each.
Michel, would you like to add something?
Yeah, I mean, I agree with everything that has been said, and I think the biggest problem is the skills availability. Not everybody do ESD. My personal choice for this lesion would have been to do an ESD, but Ian is right. ESD is not yet completely widespread in every unit, and we're certainly not in Asia where, you know, they are the leaders in terms of ESD. But I think if you have the chance to have been trained in ESD and you're comfortable doing ESD, this is a lovely lesion to offer ESD to. But if you don't have that skill set, you haven't been trained in ESD, I think an EMR is totally an acceptable choice in this specific case.
Let us move to the full thickness resection. Are you completely satisfied with the indication, technique, and so on of these 2 cases? Ball preparation as well?
Yeah, I mean, the biggest problem with using the full thickness resection device is you can only offer it for small lesion. So if you don't have a lesion that is small, this is not a good technique. I don't believe in doing repeat. Actually, I would love to hear the opinion of our Japanese expert.
Of course, we will give him.
I mean, there's a bias here. I was trained by a Japanese in ESD, so I obviously think a lot like them. But I have a very hard time doing piecemeal full thickness resection. I don't think that's a very elegant technique. But if you have a small technique that allows you to, a small lesion that allows you to take in one single piece the lesion, I think it's appropriate.
Especially with the scar,
Yes.
underlying scar
Yes.
after previous resection,
Yes.
which is difficult even for Japanese colleagues for ESD, right?
Correct. But if you have a large lesion, I don't think it's an appropriate
Yeah,
technique.
thank you so much. Jan, you agree?
Yeah, I agree completely.
Okay.
And they showed that because the larger lesion, they actually did the tunneling technique, and very elegantly,
That's
Jürgen
true.
Pohl took that out.
Sekiguchi-sensei, for me, it looks like the second case, probably the submucosal invasion, but my colleagues don't agree with me. What's your opinion?
Yeah, that is very important point. The second case.
Could you please, пожалуйста, микрофон Sekiguchi-san, чтобы он, да, please. No, it's works.
Working?
Yes.
Okay. The second case, the lesion size is actually small. However, looking at the lesion using the now dual focus NPI, there's a irregularity of the vascular pattern was seen on the surface. So we diagnosed that lesion as JNA type 2B, indicating intramucosal lesion or submucosal invasive lesion, including superficial submucosal invasive cancer and deep submucosal invasive cancer. So only with magnified NPI imaging, that differentiation between intramucosal or superficial submucosal cancer and deep submucosal invasive cancer is difficult. So in that case, we advanced to the crystal violet staining, and actually in Japan, the full zoom is available, so more detailed observation can be possible. And in that case, yeah, actually in the white light image, the lesion seems a little bit hardness, and the JNA type 2B and deep submucosal invasive cancer was suspected, but to confirm the diagnosis, I have to say that we need the crystal violet staining and magnified peak pattern diagnosis. And after confirmation, if the lesion is confirmed to be deep submucosal invasive cancer, yeah, there's two choices. One is to send the patient directly to a surgeon, And the other possibility is to try diagnostic ESD actually, and it seems that technically the lifting may be good for that kind of small lesion even if it has embedded to the deep submucosal invasive cancer, and ESD requires not long time in that case. So in Japan maybe diagnostic ESD, or after confirmation of deep submucosal invasive cancer, sending the patient to a surgeon directly.
Thank you very much for your valuable comments. Chris, would you like to add something or no? Well, let us move to first case, gastric lipoma. You can explain to us that it's growing from 1.5 up to 4.5 centimeter, but at the same time, no any complaints. And according to EUS, it looks like as a normal lipoma, no like a liposarcoma. Would you, let's say, we understand that in some cases for live demonstration we need patients, but in the normal daily life, let's say during screening gastroscopy you find the same lesion. Would you send it or perform ESD and removal, or just wait, still wait?
I think if it was the first gastroscopy and you saw this 4 centimeter lesion, if the patient was asymptomatic, I'd probably leave it be. But in this situation, they had prospective longitudinal data that shows this thing relatively rapidly growing. So I agree with them. I'd be a little bit concerned. I think you have to have the discussion with the patient, and I think you have to be honest with the patient and say, you know, we're really not sure. This could be a benign lipoma, but we do have evidence in the past of we take these out and there's actually malignant potential here. I agree with what they did.
Jan, about technique, would you also mark all the lesions like around epithelial lesion, as they do?
Yeah, absolutely.
The same?
Yeah, absolutely, because I think you want to make sure that you really have clean margins, and that's the way you really have to do it.
Yeah, Michel?
Yeah, I think it's actually funny. I had the last year 2 very large lipoma referred to me because they were in the pre-pyloric area, and when the stomach was contracting, it was occluding the pylorus. So the both patients were symptomatic. And so the technique they use is exactly the one that you want to use. So when you tunnel, you basically can preserve the epithelium, because otherwise you'll have a very large defect. The other advantage of the tunneling, and that's a very important concept to understand, is you actually preserve the pyloric muscle. Because one of the biggest fear by taking the lipoma and snaring it off is actually to snatch some of the pyloric muscle, and that could be a problem, not only in terms of causing a perforation, but also to basically put in jeopardy the mechanism of closure of the stomach. So the tunneling technique is the most appropriate technique for those kind of lesions. I think it was done perfectly.
Thank you very much. Михаил Павлович, Кирилл Вячеславович, Олег Борисович, что-то по этим случаям. Извините, я больше дал слово, конечно, нашим иностранным коллегам, но хотелось послушать их мнение. Вы что-то хотели бы добавить по...
Ну, я бы хотел добавить вот по структурам пищевода, анастомозов, которые мы видели. Дело в том, что две ситуации. Разбужировать анастомоз проблемы нету. Дело все в том, что самое главное, чтобы не было рецидива потом. Поэтому вот как мы делаем в клинике, мы бужируем, не разрываем. Потому что если разорвали, значит рецидив будет очень быстро. Поэтому 2 варианта. Либо медленно бужируем, постепенно меняя бужи, либо разрываем, но создаем на новом буже, на большом, рубец. То есть вот разорвали структуру анастомоза и в течение 3 недель на одном и том же буже держим, большего диаметра. То есть формируем, естественно, рубец на новом буже, либо растягиваем. А просто, так сказать, разорвать баллоном или бужом, результат будет плохой. Рецидив будет через неделю.
Кирилл Вячеславович, есть вопрос к нашему иностранному коллеге?
Ну, я по-русски, если можно. Меня интересует отношение к необходимости закрытия дефектов после достаточно больших резекций слизистой, как в правых отделах, так и в левых. Насколько это целесообразно, это один вопрос. И как часто это вот в практике докторов они реально выполняют.
So this is a very interesting question. The colon, when you do a full thickness resection, you always have to make sure that actually you still have access to the lumen. The limitation of endoscopic resection, full thickness in the colon, is if you have a full-blown perforation, you may actually lose access to the lumen. So you basically find the scope in front of a hole. So the very first rule is one, you have to be using CO2. Those procedures cannot be done without CO2. Number two, if you are exposed to a full thickness opening during a resection, one of the most important things is to figure out a way to preserve at least one of the lateral wall during the dissection. Because if you don't preserve one of the lateral wall during dissection, you literally have your scope looking at the peritoneum. If the defect is very large, you really have to use either the technique used by our Asian colleague, which is using a double therapeutic channel scope with a loop and clips, or you can use the Apollo suturing device that we use in the Western country, which we have access. If it's small, you can actually use the Ovesco system, which is very elegant and can be very can basically resolve your problem.
Well, thank you very much for a very interesting discussion. And now we have the rest up to до часа 20 у нас перерыв сейчас, и в час 20 мы возвращаемся в Гамбург.
Но это проблема клиентистов, которые так